We're just waiting to connect to YouTube, and it looks like we're live.
Very good. Good morning, everyone. I'd like to call this meeting of the Patient Protection Commission to order and ask Ms. Mayville to call order or call roll.
Good morning, everybody. Thank you, Chairman. I will start with our voting commissioners. Dr. Packham.
Here.
Dr. Barron.
Here.
Teresa Bohannon.
Here.
Bobette Bond. Bobette Bond. Is Bobette with us?
I did see her join a little bit earlier. Maybe she's having connectivity issues.
Okay. Jessica Flood.
Here.
Flo Khan. Is Flo Khan with us?
She's muted.
Here, sorry, I was on mute.
Okay. Dr. Khan.
Present.
Yarleni Roa Dugan.
Here.
Sean Shaner.
Here.
Dr. Slonim.
Here.
Mason Van Howling.
Present.
And now moving on to our advisory commission members, Heather Korbulik,
Present.
Barbara Richardson,
Morning, everybody.
Richard Whitley. He's coming a little later.
Yep.
Okay. And on to our commission staff, Executive Director Shulhagian
Here.
and Chief Deputy Attorney General Gregory Ott.
Here.
All right, Mr. Chairman, that concludes our roll call and we have a quorum.
All right. Welcome, everyone. Good.
Mr. Chair, it's Bobette. I'm here. I just was on mute. Sorry.
Hi, Bobette. All right. Welcome, everyone. Good to see you again, Heather. Glad you're back with us. I'd like to go ahead and get started and begin with public comment. Before I do begin public comment, there will be an agenda item later, agenda item 7, which is a presentation on patient experiences with COVID-19 in Nevada. And after speaking with almost every commissioner, what I'd like to do in this meeting and going forward is to allow public comment from patients who would like to speak to this particular agenda item, and even feel like I would like to keep this on our agenda going forward. I think it's important, given the name and charge of our commission, that we hear regularly from patients, particularly as patients' experiences evolve over the course of the current crisis. So if you planned on providing public comment from a patient perspective, I'd like to politely ask you to hold off till we get to agenda item 7, and we will keep that in order. So with that said, Sarah, do we have public comment?
Let's take a moment. I don't see anyone right now. Any of our attendees, if you can, take a moment to raise your hand and let us know if you'd like to make public comments. For anyone who is on the phone, I believe you can press *9 to raise your hand and it'll show up. So Mr. Chair, let's just take a moment and give folks an opportunity to raise their hand. We do have quite a decent amount of attendees, so if I can just wait and let's see if we see anyone. Okay, it looks like, oh, sorry, we had a couple who raised and then turned and then took it off. Okay. Okay, looks like we have one. Hi, Kismet.
Yes.
Kismet, I believe you're actually on the agenda later on in our meeting.
Oh, well, I was raising my hand in regards to if a patient wanted to speak, and I do have a patient that would like to speak. So that's
Okay, wonderful.
awesome. Thank you. That's it.
Do you have the patient who wants to speak now?
Oh,
This is
no, not right now.
later, and you're talking
Yes.
about it as
I'm
Mr.
getting
Chair.
her up. Yes.
Okay, okay, great.
Thank you.
Okay, Mr. Chair, looks like we don't have any other public comment, but I don't see that. Sorry, yeah, no more public comment.
Okay, hearing none, I'll close public comment. Again, we will have opportunities for patients to provide public comment later in the meeting, and then a second round of public comment as we close our meeting. I'm going to keep my opening remarks brief. I think Sarah and I have teed up a pretty good set of speakers and topics for today's meeting. What I'm hoping to accomplish as we roll through this meeting and future meetings is fewer, tighter presentations and more discussion among commissioners as we work out potential bill drafts and policy recommendations over the course of the summer. I appreciate all of the feedback I've gotten from commissioners in putting this agenda together, and I think we're starting to hit our stride. I will promise at the outset we will not have a 5.5-hour meeting, and appreciate everyone's patience as I continue chairing this commission. So with no further ado, I would like to move to agenda item 4. I hope commissioners have had an opportunity to review the minutes of our previous meeting held on June 22nd and would like to see if there is a motion to approve.
This is Tony Sloan. I move to approve the minutes.
Thank you, Tony. Do I have a second?
Dr. Khan, second.
Thank you, Dr. Khan. Is there any discussion? All right, all in favor of approving, say aye.
Aye.
Any nays? Hearing none, the minutes are approved. I'd like to move on to agenda item 5, which is a standing update from Caleb Cage with the state of Nevada. Caleb is our COVID-19 response director and oversees disease outbreak management from the governor's office. Caleb.
It looks like Caleb just needs a moment to join us, Mr. Chair. I think a couple of minutes.
While we're
Sorry.
waiting, yeah, go ahead. While we're waiting for Caleb, I've participated in a number of Zoom meetings like most of us here. And I think what I'd like to ask is throughout the meeting, if commissioners have questions, in addition to unmuting yourself, maybe raise your hand to give me an indication that you have a question, and I will try to take those to the best of my ability in order. Sarah, do we need to recess for a minute or two until Caleb joins us? You're on mute. You're on mute. Sarah, we can't hear you.
Mr. Chair? Yeah, I think that if you can take a 5-minute recess just to give him a moment, that would be my recommendation.
Okay, let's take 5 minutes, folks, and reconvene at 9:17.
So do you want us to log out, Mr. Chair, or just take a break?
No, please don't log out. Just maybe mute your lines for the time.
Okay, thank you.
Thank you.
Hi, Caleb. Oh, hold on one. Okay, great.
Sarah, can you hear me?
Yes, I can hear you. Wonderful. Thanks. We're on a recess right now, and we're gonna jump back on in about 2-3 more minutes. We just wanted to give you a couple more minutes to get on.
Test, 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 test. Hi, Sarah, can you hear me?
I can. You look good. You sound good.
Great, thank you.
All right, folks, we'll get started in 1 minute. Okay, it looks like I have my majority of my commissioners back. Let's turn to agenda item 5 and an update concerning the status of COVID-19 in Nevada and outbreak management. Welcome, Caleb Cage. Thanks for joining us again.
Thank you, Dr. Packham and members of the commission. My apologies to Sarah, who works extremely hard to make these meetings efficient for all of you, and my apologies to all of you for taking extra time from you this morning. Just too many competing things going on right now. I'd like to give you a brief update on where we stand with COVID cases in the state of Nevada right now. We are at, as of 9 a.m. this morning, we are at 22,909 statewide cases and 537 deaths associated with those cases. Interesting uptick recently or continued growth in our statewide testing capacity at about 377,000 PCR tests performed, 376,887 here this morning. As you all know, the governor signed a directive 024 on June 26th that went into effect on June 28th, which required masks. And there have been a number of enforcement measures associated with that. We anticipate seeing, starting to see response or the effects of that later this week or sometime this week and into next week as we go forward. We're also working with local government as well as partners throughout the state to make sure that we have compliance and we have enforcement mechanisms going forward here. As far as hospital capacity is concerned, we've been in near daily or actually daily and oftentimes several times a day with the Nevada Hospital Association and are continuing to monitor their capacity. And while ventilator use and ICU beds and others are continuing to expand based on confirmed and suspected COVID-19 cases, we continue to we continue to be in a relatively steady place with our hospital partners in that capacity. I know we have several members of the Hospital Association represented here, and many of you probably saw Dr. Sloanham's comments to the Reno Gazette-Journal last week, where he indicated as much as well. We are continuing to increase the capability for the state for contact tracing and ensuring that we have the ability to identify cases as they occur and to create opportunities for interventions for those people who may have the virus, but may be asymptomatic and not necessarily know that they have it. And our ability to conduct contact tracing efforts is continuing to expand and to show tremendous results. So that's a very general high-level overview of where we are right now. Mr. Chairman, I'd be happy to take any questions that you or your commission members may have at this time.
Thank you, Caleb. Any commissioners have questions to begin with? Dr. Khan.
A quick question, Caleb, on this mask requirement. There is, at least from the media, the compliance is not necessarily close to where it should be. So where are we with the implementation of compliance? It's been a week now since it was implemented.
Thank you, Dr. Khan, and Caleb Cage for the record. So the governor announced the mask requirement on June 26th. It went into effect on the morning of June 28th. We have seen some really great compliance measures throughout the state in some areas. However, it's certainly not where we want it to be. And I think you all likely saw Governor Sisolak's comments last week about the numbers that the Department of Business and Industry, through their Occupational Safe and Health Administration, were able to find based on their compliance efforts. We're continuing to monitor that and continuing to take steps to make sure that we can increase compliance. That starts with making sure that our local regulatory bodies, licensing boards and licensing bodies at the local government are enforcing this, but also making sure that we have all of our state agencies that are able to participate in the enforcement measures associated with this, that are conducting that. And that's something that we are really trying to refine our approach to right now. And I believe we have some pretty good solutions that we're going to be looking at here in the near term.
Teresa.
Teresa Bohannon for the record. Caleb, can you walk us through contact tracing and how coordinated the efforts are and what the compliance looks like among people who have been contacted and what kind of information they're given? Again, I'm a little concerned that people are not getting the kind of information that's in a coordinated effort to understand what their risk is, and with the time period between testing and getting results, how much exposure could be happening, especially among asymptomatic people.
Sure. Thank you very much, Caleb Gage, for the record. And I know we have some folks here from DHHS who may be able to answer some of the questions more specifically than I can. But what I can tell you is that in January, the public health districts in the state, as well as the State Division of Public and Behavioral Health, had a contact tracing capacity that reflected a non-pandemic workforce. In other words, a minimal set of contact tracers at Southern Nevada Health District, Washoe County Health District, and other agencies. It was the appropriate level given the lack of a pandemic. I can tell you that in the last 2 or 3 weeks, based on contracting that has been conducted through the Division of Public and Behavioral Health, the Department of Health and Human Services, over 250 contact tracers have come online and have been conducting the outreach efforts associated. I know that last week we announced that about 1,500 cases had been identified through contact tracing. I do have copies of the scripts and everything that they use in the disease investigation and contact tracing efforts. I don't have those in front of me, but I know that the information relates to what they need to do to get tested and how they can isolate and really what that intervention looks like.
Additional questions for Caleb? Babette?
Hi, Caleb. Thank you, Mr. Chair. I'm traveling. Can you hear me okay?
I can hear you fine.
Oh, good. Okay, perfect. So I have two things I wanted to just get on the agenda, Caleb. In addition to the contact tracing, which I think we should, I'm glad for that question. I think we need to do get a better idea how that gets better. I would like us to, in this group, see what WebIZ can do to both collect who's been tested, collect who has antibodies, collect who gets the vaccine as we move forward in trying to deal with the COVID virus. And I don't know which agenda item that should be on, and I raised it as in a previous meeting, but I know, Sarah, that you're trying to get to actual proposals. So I think this really becomes a proposal, a policy proposal to use WebIZ. But Caleb, while you're on the phone, and I know we have a big agenda, what would be the next steps in that, or DHHS?
Thank you, Bob. This is Caleb Cage for the record. I know that there is I've spoken to several people in the state about the information sharing pieces associated with that. And I really would have to defer to partners at DHHS regarding how all of those pieces work together, as they own those programs and really are the subject matter experts. But I do think that is, I do know that is something that the commission is considering and maybe an appropriate future agenda item.
Thank you, Babette. Did you have a second question?
I think Teresa did a good job in trying to get that on our agenda. How do we follow that over time, the contact tracing issues, as people go back to work and as contact tracing needs to speed up? What suggestions can we have from the commission to support that?
Okay.
Resource that?
Yeah, okay. Howard, I believe you had a question.
Yeah, Caleb, I was Howard Baird for the record. I was wondering, there's been a huge influx in the last 6 weeks of asymptomatic testing being performed as a preparation for surgeries, elective procedures, admissions to the hospital, things like that. And I was wondering whether or not there is data that segregates out asymptomatic tests from people who are coming in with symptoms. In other words, it might be interesting for the public to know what percentage of people in Nevada that are being tested for reasons having nothing to do with symptoms are turning up positive, as opposed to people that are showing up in the urgent cares or emergency rooms with active symptoms. I was just wondering if anything in the data is able to segregate those things out.
Thank you, Dr. Barron. Caleb Cage for the record. There are several data points that I think speak to that specifically, and one is the contact tracing numbers. Oftentimes that is, those are contacts of people who are identified positives that are more likely than not asymptomatic or have flight symptoms because they have not flagged themselves or their own symptoms in order to get a test. So those are folks who the interventions are working really well on. I know the numbers are higher today, but last week the number was about 1,500 cases that had been identified, which is not insignificant, especially since the contact tracing effort is really standing up right now. The second piece is that I think shows that is, anecdotally talking to the hospital association, they're getting more folks who are coming in knowing that they are positive now versus coming in and having to go through a testing regime in order to go from suspected to determine. So those are numbers that I think show our increased capacity and capability. And I think you're exactly right. The more we can get that information out, the better. And Mr. Chairman, I do apologize. I have a briefing I need to step into right now. I'm very, very sorry for keeping you all waiting and for leaving now. I just need to go take care of something right now, and I'll coordinate with Sarah if there's more that I need to respond to at a later date.
Right, understood. Thank you. And we may have a follow-up or two with you after the meeting. Thank you, Caleb.
Thank you so much.
Yep. All right. Turning to our next agenda item 6, presentation of workers' experiences responding to COVID-19 in Nevada. I believe we have 2 representatives from Culinary Workers Union Local 226, as well as representatives from SEIU Nevada. And I would like to start with our representatives from Culinary. If you are ready to go, we are ready for you.
Mr. Chair,
Yes.
I just let you know that in lieu of a presentation, Culinary is going to have 2 of their workers share their experience as a patient and as a worker. Actually, it looks like one of the individuals got called in to work and is not able to join us. So if we can first start with his testimony, I'm going to turn it over to Leslie. And Leslie will read into the record his personal testimony, and then we'll move on to Justin, who is joining us today. But I'll first turn it over to Leslie.
Hi, I'm reading this from Sixto Zermeno, who was a bellman at Signature at MGM Grand. Hi, my name is Sixto Zermeno. I'm a bellman at the Signature at the MGM Grand. I've worked there for 10 years. Thank you for allowing me to share my story with you today. I want to start by saying that what people in Las Vegas need most is information. When I got sick with COVID-19, I had so many questions, but did not know if resources were available to me. After Las Vegas reopened, I worked 3 shifts completely short-staffed and in close contact with guests who were not wearing masks. My employer didn't even put a plexiglass shield up at the bell desk for when I spoke with guests wearing no masks. I started feeling sick and getting a headache, a horrible headache. I went to bed and woke up with the worst fever and body pain. I knew something was wrong, so I went to get tested. Unfortunately, I didn't know where to go. It would have been helpful to have a list of places that I could go get tested. I've been tested 4 times total, once at Thomas and Mack and 3 at the convention center. I think every person in Las Vegas would appreciate knowing where they could get a free COVID-19 test or where their insurance covers their testing. The second way I think I could have had my support when I got positive COVID-19 test results is a clear policy for how to report the results to my job. I didn't know who from the company to call because the company never told us who to call if we tested positive. I was told to call several different people before I actually reached the right person. Every employer should make available to all employees a clear way for their employees to report their COVID-19 test results. The next thing that would have been helpful is for my job to report to my coworkers right away that they had worked with somebody who was COVID-19 positive. It took my job 2 days to call me back and ask who I came into contact with. Even worse, the Southern Nevada Health District didn't call me for 2 weeks to do contact tracing. Meanwhile, coworkers who I had close contact with continued to work. Gaps in company procedures to contact trace and notification put us workers and our families at risk. I'm fighting alongside my union to make sure MGM follows the proper steps to protect workers. It's wrong that they didn't prepare for handling this. I would like to have more information about how I'm supposed to keep paying bills as a COVID-19 patient. MGM is paying 14 days for a COVID-19 pay, but what about the rest of the time? I've continued to test positive 4 straight weeks now, and I'm past the 14-day pay. My company thinks I can return to work. Can I? I'm still testing positive. We also need more information on resources to pay the bills. Are we allowed to apply for unemployment if we are COVID-19 positive? When do we apply? When we do apply for unemployment, do we put we are physically and mentally able to work? As a COVID-19 patient, I wish I could also get an email or text notification that lets me know that my test results are in. It's a process to log in over and over again to see if my results are in. It was hard when I was really sick with a headache, and one of my personal symptoms was eye pain and pressure. So it was hard to look at my phone and check the website over and over again. I also think it would be great for people in Las Vegas to have a better mental telehealth resources available while they are trying to recover from COVID-19. There is some anxiety that comes with it. You worry about dying. You can also enter into a little bit of depression when you're isolated from your family. A lot of things go through your head about not being able to see your loved ones for a while, or maybe even ever again. You also get anxious about the future. I worried about my daughter's future because her mom also works at the same place that I do. What if her mom got sick too? Where would my daughter go? A readily available mental telehealth resource would be nice to have access to. Lastly, I would say that if I ran out of Tylenol or other medications that I needed to feel better, I wouldn't know where to get more without spreading the disease. Luckily, we have friends who can leave it at the door, but if you don't have that, what do you do? Prescription delivery would be good for people with COVID-19, especially if they have other conditions that need medicine and they can't get out to get it. Thank you again for listening to my stories and my concerns as a COVID-19 patient in Las Vegas.
Thank you. Next.
Okay, just on. It looks like we're going to hear from him. There you are.
Good morning, everyone. If you guys can hear me. My name is Justin Larson. I am a barista HMS host at McCarran Airport. I am currently furloughed. I took precautions like washing and sanitizing my hands frequently, not touching my face, and staying at home. I have asthma, and it is an underlying condition that makes you more susceptible and at risk to COVID-19. I didn't wear a face mask as often because we didn't know how bad this was going to be and the toll it was going to take on the world. At the beginning of this pandemic, the CDC was not saying that face masks were going to protect you, so I didn't wear mine as often. It got really bad, and they still were not talking about face masks protecting you from the virus. Now that I have tested positive for COVID-19, I have face masks with me all the time. I have one in my truck. I have 3 in my room. I don't know exactly how I caught the virus, but after the government lifted the stay-at-home order, I believe it was when I went out with some of my friends. When I first started feeling symptoms, I didn't think anything of it because I have asthma, and the symptoms were very similar of how I feel when I just get just a normal cold or just sick. I wasn't sleeping much, and I thought it was just fatigue from just being tired and staying up late. I had body aches and a cough, which normally when I get sick or when I'm tired, I feel that as well from my asthma and my allergies. My family came home from a trip, and I told them the symptoms I was feeling. My mother took my temperature, and it was 100.4. She told me to grab my food and go to my room. And that's where I've been ever since. This was on Sunday, the 21st, I believe it was. The following day, I didn't have any body aches, but I still had the cough and my temperature was still high. I did an online self-assessment, which was really useful. It's an online self-assessment test for COVID-19, and it told me to consult with my primary care doctor to get tested. Because I didn't have a primary care doctor, I looked online for free testing sites that were close to me. I found 2 of them, but one of them had a really long wait, and the other one I was having a hard time getting through. So my mom suggested I go to UMC Urgent Care. I went to UMC Urgent Care, and the process was great. I got to the door and the nurse did a pre-screening to determine if I should wait in a lobby or go to a separate room for self-isolation. I told the nurse my symptoms of feeling tired, coughing, and my fever. They gave me a face mask and I was placed in a room to self-isolate. My intake was done in the room over the phone with the nurse. After the nurse took my information, she came in to take my vitals. The doctor then came in with the test, which was just a throat swab. I also had x-rays taken of my lungs because of my asthma. About 8 hours later, I get the call from the doctor that I tested positive for COVID-19. He told me to self-quarantine for 14 days, and then if I had shortness of breath, to go to the ER immediately. He also gave me a website to register my family so that they could get tested for COVID-19 as well. At the moment, I got a little scared. Having asthma puts me at a higher risk. I told my family and my mom was in shock and my dad was upset and so was my sister. I told my mom not to be scared because I'm a fighter and I was gonna fight this. I called my friends who had hung out with before testing positive. 2 of my friends tested negative and 2 of my friends tested positive. The day after I testing positive, I didn't have no fever, no more body aches. I just had a cough. And I did start losing my sense of taste and smell. It was hard for me during my self-quarantine. I was not used to being in my bed, not doing much, let alone being in my room all the time. I would just watch Netflix and play on my Nintendo Switch. My family would bring me food to my room when I was hungry. I would wash my hands constantly and I had my own bathroom. Now that my self-quarantine is over, I have been called back to work. I will be going today to pick up my badge. I will continue to wear my face mask and keep taking extra precautions. It took the health district 10 days after I tested positive for COVID-19 for them to reach out to me. When I was trying to find testing sites on health district website, it was hard to navigate. I kept getting redirected to the CDC's website. As a COVID patient, I think we really need a better information and resources. The major question I have is, what are the false positive rates? Also, I'm allergic to so many different things that I can get sick with sinuses in a heartbeat. And I often have the symptoms of COVID-19 from a regular cold because of my condition. How do we differentiate the 2 illnesses? As a culinary union member, I have fought hard to keep my health insurance and I don't want to lose it. It is affordable and high quality. I have asthma and my health insurance is critical for me, especially in the middle of a pandemic. Thank you.
Thank you, Justin. I believe Dr. Khan has a question.
Yes, a couple of observations. One, regarding public knowledge and awareness of the availability of tests and the locations. The RJ publishes pretty regularly what is open and what is closed. To me, it would be helpful if the papers and the TV channels as a public service would give a list of places where the tests can be done. That would be very helpful for people, awareness of where to get it done rather than navigate on the website. Number one. Number two, as I understand, most, if not all employers, they have a process of reporting things like this particular individual at one property to their immediate superior about any issues that they may have health-wise or otherwise. And most properties do also have a nurse line to navigate their challenges. I don't know what was available at that property. I guess he mentioned Signature. So that is something perhaps the properties could do something about to make sure everybody is aware if they are not aware about the process of escalating their issue health-wise and otherwise. So those are 2 of my observations on the presentations.
Thank you. Teresa?
Thank you, Chairman. And thank you to the patients that testified, Jason and the previous patient. I think they highlight the need for ongoing testimony from people experiencing this firsthand, because it definitely highlights my concern, which is that people are not getting the information that they need, and that that the health districts are probably doing the best that they can, but we need to hear from them. because it's unacceptable that 10 days goes by before a contact tracer contacts somebody. I have my own personal anecdotes on this. I'm not really prepared to share them today, but I can tell you that I don't think that we're doing all that we can do, and that we need to improve the system in terms of what kind of information is getting to people, and how they are supposed to take all the different information and know how to navigate this system. It's already a complicated system, and I think a pandemic just makes it more challenging. So I'm just recommending that we hear from both the major health districts and from the rurals to understand how coordinated the response is, because my concern is that it's not coordinated, and that people are trying to figure this out on their own, and we're just going to be continuously fighting an uphill battle.
Mr. Chair, I can follow Teresa's comments.
Yes, Mason. Go ahead.
Thank you, and I appreciate the patient's testimony as well. And just to answer one of the questions that the last patient had regarding the sensitivity of the COVID tests that the gentleman had, the previous gentleman, both at the Thomas and Mack and the Convention Center, it's a 97+% sensitivity rate. So highly accurate test. And I agree, 10 days is far too long. The way to stop the spread is obviously identification, testing, quarantine, but also contact surveillance. And I think we know the rate, Dr. Khan and Dr. Barron, you probably know the rate of spread, but it's very significant. And what we're seeing at those sites at the Thomas and Mack Convention Center and also the Texas Station, where they all told they're doing about 4,000 tests a day, is we're seeing, talking about asymptomatic patients, well over 10%, 15% asymptomatic rate. So as we've learned and evolved since February, initially we thought it was difficulty breathing and the 100.4, but when people talk to me just kind of offline, or, hey, I've lost my sense of taste or smell, I know immediately, or have a slight headache or just not feeling well. And at the rate we're going, I'm predicting one in four will have it by the end of the summer. So if we don't get a handle on contact surveillance and tracing, and you go 10 days of not knowing, or at least being contact so others know, I think that's a dangerous path for our state.
I think Bobette has a question. You're muted, Bobette.
Thanks. I wanted to thank both the culinary patients for speaking, and I think some of their issues are work-related issues, and I know with special session coming up, there'll be more conversations about what should happen at the workplace. But I really want to back up what Mason just said and what both patients just said and what Teresa said about the contact tracing. I mean, you listen to Caleb, and we as a commission at a policy level kind of hear that they're working on it, but I think there is a real disconnect between how fast testing can be and how well contact tracing is working. We've done a lot of testing while we had the health center open, and then once the culinary health center closed, we worked with UMC and did testing, as UMC is still doing, over at the convention center. And the employers, some made it mandatory to be tested before you could return to work, and some have made it optional. And I think that's been hard. But the testing's working, right? So the testing gets done, it's easily available, and it can get turned around. I agree with, we have to do a better job of telling people where to go, but it does get turned around. UMC is turning the tests around in 24 hours, and we watch that week after week, and that works. What doesn't work then is the baton pass to the health districts to really get that contact tracing done quickly, because all that time that patient's just, either got to be in their room, like we just saw, or and it's taking too long to contact trace, or even if they're not in their room, it's taking too long to contact trace. Those people are out there for 2 weeks, and we're not getting a handle on it. So when we get to policy recommendations, I know we have to start drilling down. I really think the resources needed to pay for testing and to contact trace should be something that we try to create a system for. For payment, there's 3 different kinds of testing going on. There's the employer testing, there's when somebody's sick and then our insurance should pay it, and then there's the prevalence testing that we need. And I don't think the funding for prevalence should be paid through, that should be paid through the state, and I don't know if it is. I think that federal testing money should be used, and I don't know if it is. And then contact tracing, I just think that we're so far behind the ball. I hate to say it, but I don't think we're on top of this, that we need to see how to resource it. And those are not specific enough to be helpful, but I think it's where our attention should be.
Okay. Dr. Khan?
So following up on this same subject, first and foremost, I would like to really commend Mason and UMC. They have an excellent process. I have had experience with people I've known. It's very efficient, very prompt, is excellent. Having said that, they are supposed to notify the patient if it is positive, and it's the time they're giving is within 24 hours, which is great. Having said that, I'm presuming, and Mason, correct me if I'm wrong, that if it is positive, the health district gets notified to take it up from there. It's not UMC's responsibility or the testing people's responsibility to do that. I think that's where the gap is. When they notify, if they're notifying the patient, I'm presuming they're notifying the district. And what testimony said 10 days, that's really not acceptable. I mean, they should really get onto it if you're going to get a handle on this control business of getting to the contacts, et cetera, earlier than 10 days. Maybe at our next meeting, we have some testimony from them to make a presentation. What are they doing or what they should be doing going forward? And at least the commissioners can ask them questions and the state can look at it, what their challenges are.
Just to answer Dr. Khan's question, so just so you know, there is a process, and you heard from the gentleman speaking that he was notified, but we have the UMC Connect, the app via Epic, that you can actually get the results as it's coming off the analyzer. You get it faster than your own doctor, but we also call our patients just to let them know about initial positive and that the please stay home. And then that every test, whether it's CPL, Quest, I know with Renown and all the other hospitals, there's a interface back to the health district so they can start the process for contact surveillance. But we initially start the phone call, let them know that they're positive so they can start the process. But it's kind of a mixed bag. I'll tell you, you hear a lot of stories and people, once they find out they're positive, that they're the only one employed in the household, or they've got a household of a 2-bedroom apartment and you've got 6 people in that apartment. So it becomes very, very difficult around the social economic. And I know we talk about that extensively with the health districts on how to place somebody perhaps in a hotel or other quarters. And they figure that out, but it is a bit of a process, but we've got to shorten that window to where we get those social work intervention and case management help after they find out they're positive, because not everybody can go into a room and that has a separate sink and a bathroom, and those are the things that we're trying to work out. But I agree, Dr. Khan, it's the initial notification, but then the baton has to be picked up, and we will not reduce the spread if we don't jump on that and shorten the gap.
Thank
Yeah,
you.
I
And
agree.
I wanted to point out to all of the commissioners that you're ahead of me in the sense, but I wanted to let you know that it's on my radar screen to invite the local health authorities to come before us, ideally in the July meeting. More on that later, though. Jessica?
Yeah, I was just going to say the same. I agree. It would be great to get a presentation from them. And also what are the barriers, or, what are the needed resources that they need to really do the job, the way that it needs to be done. And then also, I know some of the rural counties are doing the contract tracing themselves. And so I think it'd be really worth it to hopefully get a presentation from those counties to see the barriers as well.
Yeah, I have a couple of local health officers that I have in mind that could speak to that, and we'll be reaching out to Dr. Putnam and Elko, maybe Dr. Bien in White Pine County. So stay tuned.
I want to say something. Sorry, I've been raising my hand.
I'm sorry, young lady. Go ahead.
Okay, so following up with the previous commissioner's comments and the patient's stories, I think that the disconnect is that we are very good at testing and giving the results back, right? 24 hours from UMC to get results to the patient. The disconnect is on our interventions. The patients don't know what to do after they test positive. And I think this is where we need to work on with the health department and maybe the doctor's offices and the places of work to really educate the patients on what they need to do to follow up. Maybe with the health district to fast turnaround, faster contact tracing, and give them better instructions.
Okay.
That's it.
I'd like to continue on with our presentations on workers' experience and now turn to the representatives from SEIU Nevada.
Okay, Mr. Chair, it looks like Dr. Swanema has a question. Do you want to answer? Oh, should I lower your hand?
Let's wait till the next conversation. I'll lower my hand. Thank you, Sarah.
Yep. Okay, Mr. Chair, I'm just give me a moment. Let me make sure all of our guests are in our meeting space. It looks like I've got Sam, Grace. Grace is available. I think Grace, I will turn to you and to Sam, and then we will go down your list of members who are going to give us their stories, but we'll start with you two.
Welcome.
Thanks, Sarah. Thank you, Mr. Chair. Good morning, everyone. Good morning, members of the commission. My name is Grace Vergara-Mactal, Executive Director of SEIU Local 1107. We thank you for the time today to talk about how this pandemic has impacted frontline workers. Workers that are risking their lives every single day to provide quality care in our hospitals, clinics, in homes, and our most vulnerable population across the state. This is an unprecedented time, and on behalf of our members, we applaud this commission and Governor Sisolak for taking on the challenge to improve the infrastructure of our state healthcare system, expanding workforce capacity and accessibility to quality care in the midst of this pandemic. Our union represents 19,000 workers, including public sector workers in Clark County and healthcare workers across the state. We are the largest healthcare union in Nevada, and our members provide essential public and healthcare service to our communities. During this pandemic, thousands of our members have been on front lines in hospitals across Nevada, including renowned Regional Medical Center in Reno, Northeastern Nevada Regional Hospital in Elko, HCA-affiliated and UHS-affiliated hospitals in Las Vegas, and University Medical Center. Our members have also continued to provide critical in-home patient support services for those that need quality care at home. Here we are today in phase 2 of reopening the state, hoping to be well on our way to phase 3. However, as the COVID-19 confirmed cases and the census at hospitals begin to rise quickly, we are extremely concerned about the safety of healthcare workers, patients, and our communities. When the state was shut down earlier this year, we surveyed our members to get a sense of the top COVID-19 issues affecting workers in healthcare facilities. Nearly 70% identified inadequate levels of personal protective equipment and lack of communication, training, and guidance from employers related to COVID-19 policies and procedures. A vast majority of workers did not feel safe going to work, and even more concerned about infection among coworkers and the risk of bringing COVID-19 home to their families. And these are valid issues because the playbook for PPE distribution and crisis management changes almost daily. We reach out to employers to address the issue of PPE levels and usage, and safe working conditions and testing or screening protocols. Some employers work with us while others did not. But I wanted to point out that to date, healthcare workers across the country have filed more than 4,000 complaints related to PPE during this pandemic. And labor unions across the country are also filing complaints on behalf of workers. Adequate PPE is extremely important, and we must come to terms with the fact that we as a state fell short in fully protecting the front line when this crisis hits us. In fact, the lack of PPE and safe working conditions became so dire in April and May that workers at HCA-affiliated hospitals hit the streets to protest, demanding OSHA intervene. Far too often, employers responded that PPE was not a problem, that all workers were sufficiently protected. Nurses at Valley Hospital like Hannah Moulton, whose husband also works at the hospital, and they both have very young children, continue to express concern about very little communication regarding policies around COVID-19. Communication has not only been inconsistent, the policies seems to change on a daily basis. Hannah found it pretty difficult to do their job when there is a lack of training and clarity around ever-changing standards and policies. Some of these policies at her hospital seem reckless. Policies like only allowing one N95 mask per shift and being told that the mask would scare patients. Or while claiming there was enough PPE, the hospital would ration PPE and require nurses to prolong its use past recommendations. The situation became so dire that Hannah and some of her coworkers purchased their own poppers for $2,000 and has yet to be reimbursed by the hospital. And due to not receiving adequate PPE, nurses began bringing their own masks to wear. But the hospital required a physician note to wear those masks on the floors. This is not uncommon themes across Nevada. And to be clear, we do understand that the economy is struggling. The hospitals have had to shut down elective surgeries. But we are concerned that corporations like HCA received $700 million in CARES Act funding and $4 billion in accelerated Medicare payments to alleviate the financial loss during this pandemic. So if the issue was money and resources, that taxpayer money should have gone to protecting the front lines and patient care. But there was no accountability mechanism in the CARES Act to ensure that this would happen. And now, in the same state, the state is phase 2 of reopening. We're seeing these same issues on the street, in grocery stores, restaurants, and other businesses serving the public. That's why SEIU Local 1107 is partnering with our union sisters and brothers at the Culinary Union, National Nurses United, United Food Workers Commercial Union, and the Teamsters, because it is an issue that would put significant strain on the state's healthcare infrastructure if we do not learn from earlier this year. You will hear from some of our workers shortly, and they will provide firsthand accounts on the mental and physical toll of this pandemic has had on frontline workers. But the bottom line is, if essential workers aren't safe, the patients and clients are not safe. And that means our communities and our entire state will continue to be at risk. I know that this commission understands what is at stake for Nevadans and our healthcare system. When considering any plan or recommendation to protect public health, SEIU Local 1107 urge you to set standards above minimum CDC guidelines to guarantee that all healthcare and essential workers in Nevada have sufficient level of PPE to protect themselves and the communities they serve. Ensure that all healthcare employees provide free testing to healthcare workers. Ensure that Nevada OSHA aggressively monitors and enforces the state directives relative to each reopening phase. And bring frontline healthcare workers to the table in a joint effort with employers to develop a plan to protect patients and workers. Thank you again for your time. And we have our members that are going to be sharing their stories as well.
Thank you.
Thank you. Liz?
Hold on, let's see. Do you want to start with Liz?
Yeah, I think Liz is on already.
Or Elizabeth, I think she's on. I just asked her to start her video.
Thank you.
There she is.
Thank you, Commission. My name is Elizabeth Bolthouse. I'm the elected Chief Steward of Nursing for SEIU Local 1107. I represent University Medical Center. I represent over 1,000 nurses and certified nursing assistants. I've been an employee at UMC for over 20 years, and I work in the pediatric intensive care unit. So when COVID first came out, PPE was an issue. And late March, the Clark County the Clark County manager suspended our CBA. And this was a great source of stress for our frontline workers. We felt that we were fighting the virus, but now when our contract was suspended, we felt even more vulnerable and without a voice. Fortunately, several county commissioners agreed to meet with us weekly to hear our concerns and to help ensure that certain parts of our contract would be honored, such as seniority for layoff articles. And for the most part, my employer has been honoring our contract, except for like hours of work and floating article. That's been adjusted as UMC's needs have dictated. But PPE has been a concern, and that's added the greatest source of stress to healthcare workers. As a healthcare worker, I don't mind going to work and risk getting sick to take care of somebody, but I don't want to die and I don't want to bring it home to my family. And we've had best practice drilled into us, one-time use for PPE, and we've had to go to extended use, 1 mask per shift. And in the COVID ICU units, you stay gowned up, stay in your PPE for the whole shift. When the state was closed, our COVID cases decreased, and then we were able to go back to best practice for a short amount of time, but now we're back to extended reuse. And our PPE is under lock and key, and it puts additional stress. This rationing of PPE puts an additional stress on our healthcare workers, because we usually have ancillary staff to assist us, like housekeepers to go in the room to get trash, dietary aides to bring up the meal trays, transporters to help come in and transport a patient onto a gurney to go for testing. But because of the rationing of PPE, basically the bedside staff is doing the brunt of that work. You know, put your trash outside the room. Staff are going down to the main floor to pick up trays for breakfast, lunch, and dinner to bring those trays up to the units. Transporters are not going into the room to help slide that patient onto the gurney. They're waiting for you to bring that patient into the hallway, and then they'll help push the gurney. So PPE is a major concern. And you know, this may not be the place for this, but I know the Washington Post posted an article where there's a Fort Worth, Texas company that said they had 4 manufacturing lines that could generate 1.7 million N95 masks a week if Health and Human Services could give them the funding to reconvert those lines. And our federal government was not able to respond at that time to his request to help out. And so we feel that as America can produce more N95s, it gets back to best practices, but our government has not seized that moment to rise to the occasion. This may not be the spot to say this as well, but Dr. Barron had mentioned statistics on asymptomatic persons, and that's a huge thing that needs to get out to the public. Right now, the public thinks asymptomatic transmission is like the boogeyman. It's an urban tale. But I'm telling you, my coworkers that had turned positive had no idea they were positive. They would maybe have a child, mostly a old teenager, lose their sense and smell, older teenager lose their sense and smell. So the family gets tested and they're positive. My coworkers only had a slight headache as a symptom. I've had other friends that went to get tested just out of abundance of caution, and they came back positive. And so I really think that the public needs to know that asymptomatic transmission is real. Another concern that we have is that initially as healthcare workers, those that are in high risk categories, like hypertension, diabetes, autoimmune disease, we were asking for workplace exceptions that they could be maybe not floated to COVID units or reallocated to protect those workers. And initially they were getting 30-day ADA accommodations. Some were just getting where you would not have to take care of a COVID patient unless it was absolutely an emergency, and then you would be required to fulfill the duties of your job. And some were getting a temporary exception where they would not be floated to a COVID area. But the latest update that I'm aware of is that this is no longer being considered an ADA accommodation because it's an essential function of your job to provide healthcare, and these conditions are not being considered. And so I do think that healthcare workers, especially those with vulnerable comorbidities, do need to be given some consideration, because it does us no good to risk these workers. And then if they become ill or incapacitated, we've diluted our workforce, not to mention the humanity of it. So those are issues that we want to bring to your attention, and I thank you for letting me speak to you today.
Thank you, Liz. We have another worker. She works for home care, Kismet.
Sure. One moment. Let's ask Kismet.
Thanks, Sarah.
Kismet, you're on. I think we can hear you. We can't. There you are.
Hello, good morning, everyone. My name is Kismet Evans, and I have been a home health care provider in Las Vegas since 2016. I have 3 clients, and I receive a total of 48 hours between those 3 clients. As a home health care provider, we work at private agencies across Nevada. There are currently 240 agencies that provide services through Medicaid. And currently, Medicaid reimbursement rate set by Nevada, the state of Nevada, is $17.56 an hour. And so that means the median income for the home care worker is only $11.07 an hour. Most home care workers receive very little hours per patient, averaging 2 to 3 hours a day, equaling less than 20 hours a week. Again, the hours for the seniors and people with disabilities is set by the state of Nevada. As a home care worker, we are responsible for providing the entire care plan assigned by Medicaid, which includes but not limited to bathing, cooking, feeding, dressing, laundry, basic light maintenance, household needs. And we have been on the front lines before this pandemic even began. During the COVID-19, I am taking every precaution and measure to maintain safety for myself, my family, and my clients. But with the lack of communication and the limited resources between some of the agencies, I have all begun to feel very unsafe. Our clients feel unsafe for our health and welfare. And due to the fact that many of our clients are part of a vulnerable population, they're not able to take care of their daily necessities, going shopping, picking up their own medication. That puts an additional burden and increased responsibility on me during this pandemic, which directly is impacting my health, my safety, and the quality and quantity of time that I get to spend with my family members, an 83-year-old mother with severe congestive heart failure and an 85-year-old father with dementia and hypertension. I've also spoken to several other home care providers who are equally as frustrated by not being seen as essential home care providers during COVID-19. We do not have the option to social distance with our clients. They depend on us for all of their bathing and grooming needs, which means we're dealing with, personal body fluids. And agencies have not had standard responses to COVID-19. Some home care workers shared that they do receive PPE, while most other agencies scramble to even provide some of the basic PPE equipment for a home care worker. Clients are concerned about being able to get safe home care workers during this pandemic, and many of the clients have suspended the home care worker service and would not prevent the workers to enter into their homes for fear of COVID. This impacted the client safety, their health and welfare, and their income. And as a home care worker, we are the first on the front lines to ensure that they receive that quality care. Ms. Hill is another home health care worker who shared with me about her COVID-19 experience that started in March. She had called her agency and asked for PPEs, and she was told that there was nothing that they could do and that she would have to purchase those items on her own. The problem with that is we all know that the stores were cleaned out. There was no resources for anybody. And then a month later, she finally received some PPEs from her company, which was a 4-ounce bottle of hand sanitizer, a homemade mask, and some gloves, not sterilite, just regular gloves. She wasn't even notified that they were available. She inadvertently was going to the office for another issue. And that's when she was able to get some of those supplies. To make matters worse, she shared that she had found out that her 90-year-old sister had the virus and she was on a ventilator. And when she informed her agency about her family situation, her employer told her to be careful. Governor, if the state of Nevada sets the hours for our clients, if the state of Nevada sets the hourly rate for agencies that get the in-home care, and if the state of Nevada pays our employers, the home care workers, we need a solution to set some basic standards for the home health care industry. I know this commission is tasked ensuring and caring for the vulnerable populations, our public health and primary care structure, and strengthening our healthcare workforce capacity. All of that can be accomplished if the state looks at revising and rebuilding some structures that allow the state, the agencies, and our union to negotiate on an industry-wide basis. Thank you so much for listening to my story.
Thank you, Kismet. Commissioners, we just have one employees from Dignity Hospital, Tima.
Good morning, Commission. Thank you for having me here. My name is Tima Prieto. I'm with Dignity Health. I've been with them for 14 years, and I'm a CAT scan technologist for 25 years. I'm also a steward with SEIU Local 1107 for 13 years. When this pandemic began, my hospital was very unprepared. We had asked for policies and procedures as to how to approach this. From what we knew is that we were going to address it like any other disease or virus, one-time use, PPEs. If it was a rule out, we assume they have it. But we quickly found out that we didn't have enough PPE to do that. So on a daily basis, protocols and policies were constantly being changed. I work every weekend. So by the time I left Sunday evening and came back Friday morning, the policy or protocol to what we were going to do with these patients had drastically changed, which made things very confusing. It made it pitted departments against each other because nursing would tell ancillary workers such as myself, you don't need that PPE, it's only a rule out. And I would say, this was the policy when I left Sunday, so why is it different? Communication was lacking at our hospital. And when we questioned management, they would say that they were following the CDC. And since the CDC was constantly changing, they felt that, and they were in compliance. Being in the medical field for 25 years, PPE is a one-time use. Well, we were finding that they wanted us to wear it, you know, for extensive use. And it's to me, it was kind of disgusting. I didn't think it was fair for the patients that I would come in contact with after a rule out or a positive. And ironically, they still had us do education, which contradict what we were currently doing. We had to do this education that said, you know, PPE was a one-time use, yet we were continuing to use our PPE for extended amount of time. Who's speaking? Hello?
I think you're fine,
Yeah,
Tina.
we can hear you, Tima. You're good.
Oh, okay. Also, so it made it to the point where, because I work weekends and it's a limited amount of management there, I had to make sure that my team on the weekends would have proper PPE. Transporters, EVS personnel would come to me and said, because I'm a steward, they're like, Tima, they're not giving us N95s, they're not giving us gowns. So I took it upon myself to make sure that my team on the weekends always had the proper PPE. So my department on the weekends would hoard. We would hoard our PPE just for our people on the weekends to make sure that we could do our jobs safely. I don't think that that's something that we as employees should have been doing, to the point that we were so scared that we would take this home. At the beginning of this pandemic, management had told us that if we came in contact, that we would be with a positive, that we would be quarantined for 14 days. Well, they soon realized that if they did that for every employee, they would have no staff. So protocol and policy would change. So if you were asymptomatic, you could still come to work. A lot of us felt unsure, and we were worried that we were going to expose our coworkers. We were worried that we were going to expose our family. I had to change my practice coming home. When I wore my uniform prior to the pandemic, I never had my children give me a hug. I would say hello, but you know, I didn't want them touching me because I knew my uniform was soiled with something. But when the pandemic started, I had to change. I felt like I had to strip down in my garage and not bring my clothes in. They stayed in the garage in a hamper. I would go straight into my shower before I even said hello to any of my family members. These were the steps I took because no one told me how to handle this. Now we were being notified when we came in contact with a positive COVID patient. One time it took my employee health nurse 3 weeks to let me know, which is past the 14 days. I had been working the whole time. So God forbid if I was positive or had some symptoms, I would have exposed every patient and including my family at this point. Now I'm being told that they're not notifying us because they assume everybody has been exposed. As a CAT scan tech, a lot of the tests were coming back false negative. And the only way we could find out is through a CAT scan CT chest. And that's how they would determine if this was going towards if they were a COVID patient or not, or if they needed to keep the patient there longer because the lab work was different than what the CT chest had shown.
Ms. Prieto?
Yes.
Forgive me for interrupting you. I want to make sure that we allow enough time for questions from any of the commissioners. apologize for cutting you off, but
No, it's okay.
any of those of you who have presented could just hold on for a second, and I want to make sure commissioners have an opportunity to ask any questions if they have them. Dr. Khan?
Just an observation in the testimony we heard. Obviously, the major issue has been the PPE, and we heard from some of the healthcare people about being issued one mask for the day. As I understand, of course, we all know about the challenges of PPEs when this all started. There were hospitals using the mask for 5 days, et cetera, but that's passed. Having said that, I do not know of any business or healthcare facility rather that would give the staff a mask, for example, N95, more than once a day or more than once a shift. So I think that's pretty much generally accepted nationally. Under the circumstances, they cannot be getting a mask for every time they go to a patient room and change a mask. That's just not done. So if a facility is, in my observation, is providing a mask for a shift to a staff member, to me, that sounds reasonable given the environment we are in.
Teresa, I believe you have a question.
Yeah, hi. I just want to first start out by saying thank you to Grace and Kismet and Tima and Liz and all the healthcare workers, the frontline healthcare workers. You literally are saving lives and putting your life on the line for everyone. So thank you. And I think the PPE thing has been an issue across the country. We've heard so many anecdotes. I think that we can say with a fair amount of certainty that it is an issue. And I would request that we have a constant update from Caleb about what the status of PPE is for the state and what procedures are going to be put in place to standardize that hospitals, home healthcare workers, you name it, are not fighting with one another in a competition to procure that PPE. I'm also curious, Chairman and the rest of the commission, if we don't think about an early warning system based on some key metrics and that we can tap into emergency systems like getting a text message. So every resident in the state of Nevada gets a text message indicating that we're at a higher risk of community spread and that they should be reducing any kind of activities that would put them at risk of transmission. And I don't know how we would do that, but I'm just wondering if that is a way that we could get information out to the general public about some of the issues that we've heard about asymptomatic transmission and kind of where they can go to get tested, or if they have concerns, if they need support, all those kind of things that could come through a centralized system. Because I think what separates the United States and our response is that we do not, and other countries that have successfully tackled this pandemic, is that we do not have a centralized system. We do not have a way to kind of bring all the information into one place and to get it out to the citizens. So that's
I believe those are questions we can put to Caleb. If not, hopefully he can direct us to someone who gives answers to those. We'll inventory those. Other questions?
I have a question.
Okay.
Actually, or a statement in regards to the PPE, and this just recently happened this week. We are so concerned about conserving the PPE, but we are not having the ER physicians adequately assess a patient. I had to scan a patient 3 times, which meant I used the same mask, but I had different gowns and gloves on the same patient. First, the patient, we just scanned a soft tissue neck. Then they realized that there was something wrong abnormally with the chest. I had to go back and do the chest and 3 times I did this with the patient. So there needs to be a system with the doctors that they truly assess the patient so that we conserve our PPE.
Dr. Slonim.
Thank you, Chair Packham. I want to share my appreciation with all of the folks the patients, providers who have shared some personal experiences today and testimony. It's so helpful to round out the frame of what's going on in COVID. I think I'm thinking about trying to contemplate how we move from individual stories to more systematic, organized approaches so that we can be supportive of some of the risks, knowing that we may not have full understanding of systematically what the data look like across a broad spectrum. We have to be able to figure out if we're responding to a systematic problem or not. And I think to the point that you were alluding to, Chair Packham, we have people in charge. We have people responsible for those things. We have to hold them to bringing forward the information and helping us as a commission to organize ourselves around, there's a disconnect between the stories and the systematic data, and we have to reconcile that. At least that's what I'm feeling at the moment.
You know, on top of that, I totally agree with Dr. Slonim, and I'm wondering if we could also get some patient perspectives from the north and the rurals as well, just to make sure that we're getting that full perspective. And maybe even if we could get a running list of the gaps that we're hearing from the patients, because I agree, this is so valuable to kind of hear, you know, where the gaps are in the system.
Okay.
Yeah, just one more point I would make. I actually think, and there are systematic ways we could do this, rather than having, I love the texture and the granularity of the stories, and there's a need to be able to, if we're going to respond, not have them be anecdotal, but have them be systematic and data-based as we're moving forward. And there are important ways in which we could collect patient and provider level information, just do it systematically so that we know we're not responding to one-offs in a particular institution. It makes it difficult to organize ourselves around.
That is a great point that I think I'd like to take up when we get to the work plan part of our discussion today and how to collect that information. I'm in complete agreement with that. I love the anecdotes, but I would love to see more comprehensive information on what's been discussed so far. I do want to thank all of our presenters and am reminded that the occupational health and safety issues that were discussed today are inseparable from the larger issues of how we deal with community transmission. I'm also reminded that essential health workers are not limited to those in hospitals and other healthcare settings. They also include home health and personal aides who are literally out on the front lines. If I could then again, thank you to our presenters on the workers' experiences. What I would like to do is take advantage of my prerogative to take items out of order and turn now to agenda item 8, which is a presentation on health workforce development through licensure compacts and reciprocity. We've got a guest presenter who's got a brief presentation, but more importantly, going to take some of our questions on what's taken place recently with the extension of waivers on all sorts of licensure issues. And our presenter is Lauren Block from the National Governors Association. Lauren's been a great friend to the state of Nevada and has assisted my office and a number of folks on this call today on a wide range of workforce issues. And just one thing that I love about speaking with Lauren is we never have to reinvent the wheel. There's always some other state in the country that's innovating, and she's going to share a little bit of that information with us this morning. Lauren, are you ready to roll? I think you're on mute, possibly.
All right, can you hear me now?
We can hear you now. Welcome.
Oh, now I can't hear you, John, but I assume you can hear me.
Yeah.
Okay. Sarah, can you just give me a thumbs up if you can hear me?
I can.
Oh, you can. Okay, great. Sorry, I was trying to do phone audio, but it wasn't working.
No problem.
So
I've got your
thank you for
presentation
having
up.
me, and thanks for those kind words, John. I've always really enjoyed working with the state of Nevada. And per your request, I am going to speak briefly today about the health workforce in Nevada or opportunities for the health workforce during and post-COVID. COVID has certainly magnified challenges states are facing in the health workforce. We just heard from several people about folks in long-term care settings and at homes as well, which is an area we're also focused on in our work and doing a lot of tracking. Our website has a lot of information. But it's also put a spotlight on opportunities. And one thing is for certain that recruiting and retaining talent and creating mobility for people to come into the state to ensure sufficient access are both really critical. So can you go to the next slide? Or do I have, I don't think I have control, right? So. Okay, so just very quickly, I do work for the National Governors Association. We are, I'm part of the Center for Best Practices, and we function as something between a think tank and a consultancy for states and work in partnership with the lobbying arm of NGA. And Nevada has actually been in multiple health workforce projects that I've been part of. So next slide. So the two things that I really want to focus on today are the long-term policy considerations for the health workforce in the context of COVID surrounding licensure and telehealth. I'll be very brief about telehealth because I know you guys have already had a conversation about it, but I'll just briefly touch on a few opportunities. Next slide. So, and I wanted to put this all in the context of some key questions. So there are certainly several federal and state emergency flexibilities that are in place right now. And there is a question as to which ones will become permanent. And if some of the federal flexibilities go away, what does that mean for the state? And what pieces of things might you want to continue? You also want to consider what was the state of the health workforce before and as a result of COVID. And what is that unmet need, both in that normal environment as well as the pandemic situation geographically and by specialty. And I'd be remiss if I didn't mention the importance of health workforce data to help you strategize and implement appropriate rapid response. I know John presented on this topic recently. That ability to collect data and help it to inform policy is always important and can be strategically leveraged to help with COVID response. And a really great example of that is used to help allocate and plan resources for robust data collection. Indiana is a great example of that. They were able to leverage their robust data collection for all licensed practitioners to identify facilities which had shortages and match them with students and volunteers and professionals, licensed professionals. So they had a robust system and they were really just ready to begin contacting their licensees and working with that information. Next slide. So I want to speak briefly about interstate licensure compacts. There are currently 5 of them in place. Nevada is involved in 2 of them, and I'll mention as I talk about each one. In general, for anyone who's not familiar, interstate compacts are agreements between 2 or more states and are recognized as a tool for interstate cooperation on a national and regional basis. Currently, Nevada participates in one that is the Interstate Medical Licensure Compact, and then also in the psychology called PsyPac. And while the fundamentals of the compacts are similar, there are some important nuanced differences, but these compacts really do help with mobility for individuals, both in an emergency situation, potentially, depending, and then also just when folks are moving and trying to quickly go from state to state. So the medical compact, I won't speak about it for long, but there are 26 participating states. And again, Nevada is one of them. What it does is it really allows for access to a centralized application for an expedited license in compact states. The physician has to pay a fee to use the process and still has to pay a fee in each state in which they they're participating. So it's not like a one and done. And again, Nevada is part of that. The next one I want to talk about is the Nurse Licensure Compact. This is the biggest compact with 34 participating states. Nevada is not one of them. Unlike the Interstate Medical Licensure Compact, the Nurse Licensure Compact offers licensure reciprocity for nurses in participating states. And it can vary in how it's done. So in Virginia, every license issued in the state is a compact license. So it's very straightforward. In other states such as Indiana, nurses have the option to hold only the Indiana license, or they can have an Indiana license and separately apply for the compact license. And nurses who are participating are subject to the scope of practice policies in the state in which they're practicing. So this one is more flexible and has lower costs for purposes of the licensee. There's also a physical therapy licensure compact that has 21 participating states, and the licensee has to separately apply for and purchase a compact privilege for each state. And then again, they practice under the license where they're practicing. And then there is Replica, which is for EMS personnel, and there are 19 participating states. Nevada, again, is not part of the physical therapy compact or the EMS compact. For Replica, for EMS, it provides mutual recognition of EMS licenses in all participating states, and the EMS worker adheres to the scope of practice in their home state, even if they're practicing outside of their home state. And then the last one is SIPACT, and that one Nevada is part of, and there are 12 states participating, and there are two different types of participation. And again, the psychologist is subject to the state scope of practice where the patient's located. So compacts are obviously one great way to offer mobility for folks to be able to practice across state lines. That might be via telehealth, or it might be in person, depends also on the state's telehealth rules. But absent compacts, states should also consider, it's worth considering how challenging it is to get a license in the state. The more time intensive and complicated it is, the less likely a practitioner may be to pursue a license. And I know in Nevada, all the boards are independent and operate separately, but that is something worth looking at, how you compare in terms of the amount of time it takes for a licensee. Next slide is a couple of other, so here's actually just so you can see which compact Nevada is part of, so, and the totals underneath. And then the next slide. So there are a couple of other types of opportunities I wanted to briefly talk about. One is that Nevada is a member of the Uniform Emergency Volunteer Health Practitioner Act. You're one of 19 states participating, and that helps recognize out-of-state licenses from member states during a public health emergency. A few other things that are slightly less common, but I wanted to just highlight for you as examples, is that within the last few years, I think actually these next 2 points are both recent, just the last 2 to 3 years for all the states. Arizona passed the nation's first Universal Licensing Recognition Act, and that provides a temporary 1-year license for providers licensed in other states. So during that period, the provider has to go through the process of getting an official license, but they're still able to practice. So it is a facilitator to working in a state in person or potentially remotely. Similarly, Montana, New Jersey, and Pennsylvania do have laws that require occupational boards to allow individuals with out-of-state licenses to practice. And then there are some states that have a version of a universal license, but it really just applies in emergency situations or national disasters, as long as you're in good standing in your home state, and the states here are listed. Also, I just did want to note that NGA has done a few memos in response to COVID, and we highlight many different examples of what states have done surrounding their workforce in regard to COVID response specifically. So there's a link there. Next slide. So another key issue that I wanted to briefly talk about is scope of practice. Scope of practice, as you may know, governs those laws govern the practice authority and of a given practitioner, and it can influence where individuals decide to practice. So states that have less restrictive scopes of practice may attract a higher number of graduates than states with more restrictive policies. And so what we did here is just, and this was on that other slide too, we're just showing you how you compare to your surrounding states. I'm sure you have other places where people tend to move from, but it's always good to know kind of what's going on in the border states and where people might more easily move. I know we have a lot of big states out west, but we always kind of like to look first at the neighbors. And so you can see here where there might be some opportunities. I do want to note for nurse practitioners that there is full independent practice authority, but there's a transition window to that. And there are some places here where Nevada, I think, is ahead of the pack. For instance, in oral health, you have no supervision required, full independent practice for dental hygienists. And there are very few states that have that. I think you're one of only 5. And for dental therapy, I think there's only 15 states that have dental therapy. So, you know, here are just some of the examples, and there's a lot more information about this on NCSL's website, scopeofpracticepolicy.org, where you can see maps and different things to compare. But these just can show you how at least you compare to your neighbors for where, you know, some of them might have more flexibility than you do. Next slide. So again, I don't want to spend a ton of time on telehealth because I know you've already had a presentation and talked about it, but I did just want to note some of the major areas, categories that we think of when we think about telehealth. So certainly coverage parity, are the services covered that are in person that are possible to do via telehealth. You do have a law around that for commercial insurance, payment parity. There is no law requiring payment parity for commercial insurance providers, so you could pay less for telehealth services, which may be deemed appropriate if the costs are in fact lower. Distance in originating sites in terms of where folks can be, you do have some flexibility there. When it comes to modalities, you do reimburse in Medicaid for live video store and forward, but not for remote patient monitoring services, which is certainly an area that I think everyone is thinking about more and more when we think about what's possible. And commercial insurance plans reimburse for live video, but don't have to cover the RPM or store and forward. I know you temporarily have in place flexibility for audio only, and it is worth considering, you know, the future of that. So, and especially for individuals who may have more limited broadband capacity or may not engage in much in smartphone technology and such. So, but that is something that a lot of states have given new flexibility for. I will just note that obviously telehealth has great potential, but there are limitations and there are issues to address throughout the nation. And so some of those are surrounding privacy, security, and technology. Certain requirements have been lifted temporarily to allow more diversity of technology, but that does potentially come at a cost. And so we have to think about, you know, what it means in the longer term, and provider uptake of the technology will also depend on that. Also thinking about broadband, as I mentioned, and at-risk populations and equity issues, because not everyone maybe has the minutes or the technology to be able to equally participate in telehealth. And again, the uncertainty regarding the permanence of waivers may impact the uptake of providers. And again, we did a memo specifically surrounding telehealth. Just a few final thoughts that I just wanted to note. So again, I've mentioned it now, I think 2 times, but that expiration of the permanence of federal and state emergency flexibilities is going to be important to think about. And then also, as you think about the impact on the health workforce of COVID, rather, so the impact of COVID on the workforce. So are you having a higher number of early retirements? Are there providers who are closing, who are having sustainability issues to think about? Are individuals still graduating at the same rate from health professional institutions? I don't know what flexibilities maybe have been given for purposes of things like clinical hours or otherwise. I know some places have tried to find new ways to have more with regard to simulation, for instance. And then finally thinking about where there are potential gaps in telehealth and how those can be met. So, and then finally, again, the issue of do you have access to the data you need to answer those questions and what might be possible there. So those are just a few thoughts about things that you could be doing as a state, specifically surrounding compacts, licensure, scope of practice, and telehealth. So, thank you.
All right, thank you, Lauren. Dr. Khan, I believe you have a question.
Yes, Dr. Khan, for the record, a couple of things. One, a question is you mentioned the physician, talking about physician licensure now, could apply for expedited review. Do you know what time frame it is? I know it could be on a case-by-case basis how complex the application may be, but on average, what is the time frame for this expedited review for those states that are in the compact? And number two, regarding telehealth, CMS, as we discussed last time, has an equivalent of reimbursement for telehealth as in person. Is there any effort at the Governors Association level to consider that or create a compact for some parity and uniformity across all states?
So for your first question surrounding how long it takes to get the license with as being in the compact, I will have to look into that. I don't know. I have not heard. I will tell you that I have heard from many stakeholders and associations for there to be uniformity in telehealth. I have not been hearing that from governors' offices though. That interest in having uniformity across states. So at this moment, we're not pursuing something, but I have heard it from a lot of stakeholders.
Thank you.
Dr. Barron?
Yeah, excellent presentation. I wanted to point out something that we don't often focus our attention on in this whole process, which is that credentialing physicians, nurses, et cetera, in the state is really a small piece of the entire process that goes on. When a physician is recruited to a practice, the licensure can be applied for in advance unless they are finishing a training program. So even our residents in the state of Nevada, our people that are in GME programs in Nevada, have to wait until they have a certificate from their program saying that they are completed before they can even start the application process. The application process, in my experience in the state of Nevada for the Nevada Board of Medical Examiners, is actually fairly expeditious and can take anywhere between 2 weeks and 6 to 8 weeks to accomplish. However, it's all of the problems that occur after that and hurdles to jump through in order to get a physician credentialed with hospitals as well as with payers and insurance companies, which can take upwards of a year. So getting the initial person that's providing the healthcare credentialed in our state is just a small piece of the entire puzzle. If you actually need to be reimbursed for their services that they're providing, it takes many, many more months, even in the most efficient process where you assign somebody to do all the paperwork. So I think the commission could look at that process and see if we can apply existing state law to smooth the credentialing with hospitals and with payers. And to me, that would be a faster route to getting people up and running in our state to practice.
Dr. Khan?
So Dr. Khan, for the record, so what Dr. Barron is bringing up, that's an excellent point. One thought, and I have served on the medical board in the past, is once the medical licensing board issues a license to practice in the state of Nevada, each hospital, et cetera, and the commercial providers do their own due diligence, et cetera, and that may take very long, as he said. One suggestion to be considered at the state level is if the state licensure board has issued a license to a practitioner, the other agencies, et cetera, could accept that, at least to issue this physician a temporary license to practice within that insurance company and or the hospital, et cetera, till they do their own due diligence. And if they find an issue in their own due diligence that the medical board supposedly didn't pick up, then they could reconsider that application, but at least it will get the physician started to work in the facility.
And Lauren, is that the case in Arizona, as I understand what you presented earlier?
Well, in Arizona, yeah, they can practice. I think it's for up to a year while they're working on their actual licensure. And to answer the previous question, I just got some additional information. In some states, I believe with COVID, they've been doing expedited licensing when they're requiring a license as opposed to accepting like reciprocity. I think sometimes it's like within, it can be as short as a day, I believe I've seen, but it can be, you know, up to like a few days potentially. So some of these expedited licenses, with the compact, I think it's immediate. So once you're in, I think you just have to, it's good for 12 months and then, but you have to pay for each state that you want.
And not to put you on the spot too much, Lauren, but I was wondering if you had any data on best practices with some of the credentialing issues that Dr. Barron raised.
Yeah, I actually had, that was, I don't want to say it was new to me, but I think it's not something that I've worked on too much, but we can certainly look into it and get back to you.
That would be great. I've heard about credentialing issues as long as I've known Dr. Barron. So other additional questions? I see Tony.
Yeah, thank you. And thank you to Howard for helping us to understand this a little bit more. I think the thing I'm still struggling with is in the context of certainly great presentation, here the issues of compact and reciprocity. And at the same time, am struggling, and again, I'm not going to go down the same piece of anecdotal conversations, but let's ask the question about, what are the data from our licensing boards more generally, and how quickly are we getting through the process? I'd love to be able to work in the context of data. We're still using, it seems, in many of our licensing boards, paper-based forms and approaches. Have we not matured in this era of high tech where we're still dependent on paper-based filing? I don't even have a typewriter anymore. Never mind how to fill one out. Why are we still recreating the wheel as it relates to the licensure of health professionals in the state versus an approach that can tap into multiple data sources already online? If you want to go and see my performance as a physician, they're licensed in another state. There are 20 ways you could do that. There are ways consumers can do that. Why can't our professional boards access those opportunities and make the approach more efficient? We may be meeting imagine that there was a 120-day timeline where you had time to execute. That's great. What is best practice? How do we do it in 60 days? How do we change our process so that we can be more nimble and lead versus kind of doing it the same? And this goes for nursing home administrators and nurses and doctors and pharmacists and every professional in the state. How can we be more contemporary in our approach, even though what we've been doing may have met the historical threshold for performance?
Yeah, and do you want me to respond to that, Dr. Patton?
Please.
So, I mean, there's a lot there and there's a lot of opportunity there. You know, there's how you organize your boards is one thing, because there's a lot that can be done to centralize certain functions. Even if the boards are independent, you can centralize certain functionality and use more automation. Electronic submission with paper as not as the default, especially. And there can be, I don't remember the frequency. I'm sure each of your boards is a little different, but you know, there are a number of states that have supplemental surveys. So there's basic information that's collected through licensure, but then they have mandatory supplemental surveys. They can have smart logic in them. We've helped multiple states to refine these. They also can help with your HPSA designations. They will help you. You can do like fast surveys. I know I keep using Indiana as an example, but they have countless reports showing, you know, uptake of telehealth. What are barriers to participating in Medicaid? You know, what's going on in terms of the distribution of providers and how things are, how they're working, what are barriers to being successful. So there's a lot you can do, and we've provided some technical assistance to the state on this during the last administration, and it continues now. And we're happy to continue, but there's certainly some efficiencies in centralizing certain functions and trying to bring them on electronically.
Thank you so much for that. Mr. Chairman, as a state that is struggling with workforce issues across the board, which are accentuated in the context of COVID-19, I'd like to suggest that perhaps we can put on the work plan an understanding of these workforce issues related to licensure, and there may be a potential bill draft request that comes out of that as we move forward and start to understand basic fundamentals about where we're performing and the gaps in best practices for each of our licensure boards across the state.
I think that's actually a great suggestion, and a little bit of information on that was presented at the Sunset Commission last week. So I know that data is out there. I was hesitant to add any more speakers to our agenda, but I think we could get answers to that pretty quickly, and there is a good deal of variation. Jessica, I think you have a question, and you're muted, Jessica.
Just going off of what Dr. Slonim was saying, you know, I think we are in competition with a lot of the states around us for workforce shortages. And so there is that idea of best practices, but also how do we compare? I've heard that Nevada is comparatively more difficult for physicians to become licensed in terms of how much it costs to gain licensure and the length of time. So I wonder if there's indicators that we could even look. You showed some of the practices that Nevada is doing versus other states, but just those indicators versus like how much it costs, how hard it is to get into it, et cetera, which I think goes along with what Dr. Slonim was saying. Is that possible, Lauren?
Yeah, we can certainly look into, we'll look at what criteria we can think of and what we can find out in terms of the different processes and the steps that have to be followed. And we can also work with John also on whatever can be collected from, I mean, so the previous question about what the different boards, how easy or hard it is, I think we'd have to work with you guys internally to learn what's happening in the state, because I have heard that certain boards can be quite challenging, and whereas others are easier. So, and I think, you know, it is worth noting, you know, some of these issues are probably based in fear that, you know, we don't want to lose our jobs to people in other states. We want to make sure, but that there's enough jobs for us. But I think, you know, when you have the data, what you can see whether or not you actually have enough, and you can make the policies in accordance with that. So I think sometimes that fear is not always warranted. And so you can also do things surrounding telehealth. Like we know for COVID, for instance, there were a couple of states that said you have to allow primary care practices, for instance, to participate in telehealth, or in-network providers. Maybe it wasn't just primary care, but you have to allow in-network providers. So it wasn't just the, I'm going to use it, like the companies that offer telehealth services only, so that you can have that continuity of care. So that was like an emergency example of something, but I believe Massachusetts and Illinois took executive actions to make sure that those providers were able to serve their patients. But you know, data is powerful in helping you better kind of tell the story, but we can certainly help you.
Dr. Khan.
So, Dr. Khan here. So a couple of thoughts on this. Number one, perhaps rather than bring every licensing agency to testify, one could get them to submit to us in writing their processes that currently exist. So that may be more efficient, and we can compare and contrast with what's happening and see where there's commonality that can be done. Number two, the challenge with the licensing board is that historically there have been a lot of documents submitted in their credentials, whether it's their degree or the residency program, that were not accurate, that were submitted in paper, some were forged, and that came to light only later on down the road. So they need the confirmation directly from the source to the board, not through the applicant. And that delays it. However, with electronics, I'm presuming that if the residency director or wherever else they have worked, their chiefs are communicating directly with the board electronically, that could expedite rather than mailing in FedEx and all. That challenge comes with international graduates. Their information used to take much longer. Now they can also electronically directly communicate and expedite that. The other question that you alluded to in your presentation is the challenge. Even if they get the expedited license, they cannot see the patients even on telehealth, for example, if they're not credentialed by the managed care companies or those who are not insurance companies, but in another category of self-funded or otherwise not-for-profit agencies. If they're not credentialed with them, they're out of network technically. And that becomes another challenge. The license becomes a moot point if they cannot still see a patient that is not, that if they're not on their network.
Certainly. And to the first point you mentioned, we'd be happy if you wanted to do a survey or something of the licensure boards. We can help so that you can get standardized information rather than, you know, in different ways. We can help put something together so you're getting that uniform information.
Excellent. Other questions? Okay. Thank you very much, Lauren. We will be in touch and follow up with you. Appreciate you presenting to our group today.
Sounds good. Thank you.
Thank you so much. At this point, I would like to take a 5-minute break. It's 11:05. I would like to come back at 11:10 sharp, grab a glass of water, etc. Also would like to start with agenda item 9 and proceed, try to motor through agenda item 9, 10, and 11 when we return. I'm going to combine the presentations or patient experiences with the last public comment session. So for those of you waiting to present on patient experiences, if you'll indulge us, would like to get through some work plan and other discussions that need to take place, and then we will take up those patient comments and experiences in our second public comment. So I've got 11:06. Let's make it 11:11 when we return and take a quick 5-minute break. Thank you. All right. I believe I see a majority of commissioners and think we can proceed. Like to start with agenda item 9 and a quick update from Sarah on collaboration and coordination between the PPC and other state entities. Sarah.
Hi, thank you, Mr. Chair. Okay, commissioners, I just wanted to be brief with this because I know you want to move on to the next few agenda items. Quick update. I think what I'm going to do is just follow up unless I hear differently from you all. But I think what I'll do is anticipate sending you an email that kind of summarizes some of the initiatives or things that are going on with the other state entities, commissions, and committees that I've mentioned in the past, and talk to you and just kind of give you a little bit of a recap. Again, just being mindful that we continue our coordinating efforts with each of them in relation to our deadlines. So my last correspondence to you all early last week had a list of upcoming deadlines. And so I just want to be mindful of not only our work and our timeline, but theirs. What I'd like to just highlight briefly is like the Legislative Committee on Healthcare. Their next meeting is going to be on July 23rd. This commission anticipates meeting one more time before their next meeting. I believe the interim study on prescription drugs is meeting in August. And then I'd also want to bring to your attention the Advisory Committee on Medicaid Innovation. They held their first meeting last week and anticipate having another meeting at the end of this month. So I just wanted to make sure you guys were aware of it. I know I've sent you some emails about it, but I think, Mr. Chair, what I'll do is I'll plan on sending another email just kind of recapping those collaboration efforts, if that's helpful to you all.
Works for me.
Okay, but I'm here to answer any questions. If you guys have any, that's what this agenda item is here for. Otherwise, I will push it back to you.
Questions for Sarah? Okay, seeing none, I'd like to move on to agenda item 10, and that's a discussion of the commission work plan and potential bill draft requests. As I mentioned at the outset, what I'm hoping to have us accomplish over the course of the summer is fewer formal presentations as we proceed and greater discussion of potential bill draft requests. To kind of kick off this discussion, I did want to mention to you that when it comes to policy recommendations coming from the PPC, those are not, and I hope they're not necessarily limited to bill draft requests. They might be letters or recommendations that we make as a group. Last time I promised that I'd be putting together a letter to our congressional delegation with respect to the extension of the waivers from CMS, and right before I hit the send button, those were extended. It looks like that they will be pushed out till the middle of October. I think there may be a use for that letter down the road, and so I will keep it in my back pocket, but wanted to give you that particular update. So in our discussion earlier today and previous meetings, we've identified a number of topics that we want to keep on our radar screen. I'm hoping that today we can begin a more concrete discussion of potential bill drafts that we want to put on our radar screen, hear it from the commissioners. I have my own ideas, but really want to kind of open up the floor to that discussion. Sarah's shared a draft work plan that includes topics, policy recommendations, and potential bill drafts, the latter two of which are empty cells in that grid. So in the spirit of fleshing some of that out, I'd like to open it up to, and maybe start with the suggestion from Dr. Slonim on consideration of a BDR around licensing. So with that, happy to open up that discussion.
Mr. Chair, this is Mason. I have perhaps a suggestion.
Okay.
What I heard from Dr. Khan, Dr. Barron, and Dr. Slonim in regards to maybe an opportunity to expedite some of the managed care processing as far as credentialing with the payers. We're seeing more and more expansion of Medicaid, and then the shift to a managed care product such as Smart Choice and other products. But maybe there's an option that if somebody's approved in the state of Nevada and they automatically qualify for what we call traditional Medicaid, why couldn't we just default that if they're approved by the state and approved by a Medicaid plan, that they could be approved via a managed care organization, whether they're in or out of network? I see that as perhaps an opportunity to expedite credentialing, and often those physicians and hospitals are paid at the Medicaid rate, even if they're out of network with the plan. So maybe it's a quick pickup on shaving off some time. I know with our own primary care division, our ambulatory division, we have to go through every payer and get them credentialed, whether they're a commercial plan, an employer-sponsored plan, or even a Medicaid expansion plan. So maybe that's an opportunity. And as we see it continue to grow, and I know the push for the state to transition the Medicaid population on a managed care product, which I'm very supportive. I don't want to give that impression that I'm not, because I think that's the right thing to do on ensuring population health and preventive medicine, but also controlling cost. But maybe that's an option, and Dr. Barron and Dr. Khan can speak a little bit about it, but maybe it's a piece of the pie that we can expedite, and maybe just have automatic defaulting of privileges and credentialing with managed care plans if they're approved by the state, and it's a Medicaid sponsored plan.
This is Dr. Khan. Can you see me?
Chair is muted.
I'm muted. Sorry about that. Yes, go ahead. Sorry.
So I strongly endorse what Mason just mentioned, and we heard from the Governors Association that they could at least be temporarily credentialed, at least for a year, as they're doing elsewhere. That's the minimum. And I would add, in addition to that, it goes hand in hand, in my way of thinking, is the telehealth reimbursement for primary care should also be seriously considered across the board as in-person reimbursement, because that's also another challenge, as I mentioned in our last meeting, because of the shortage of primary care physicians. If we are trying to expand this, that may become a deterrent in getting the primary care providers, even on telemedicine, to continue to do that. So my recommendation for one of the bill drafts is that also be included across the board to follow the federal guidelines on reimbursement for telemedicine.
Agreed.
Go ahead, Howard.
So one of the things that was inferred from the proposal was that managed care organizations that are Medicaid providers follow suit from fee-for-service Medicaid if a provider is credentialed within fee-for-service Medicaid first. And again, in my experience, actually the managed care organizations that help regulate and distribute Medicaid services were actually faster the last time I had somebody credentialed in my practice than fee-for-service Medicaid, or quote-unquote straight Medicaid from the state of Nevada. So I'm not sure that would necessarily improve the expeditiousness of the process. Somebody pointed out to me after one of our early sessions that there is actually a law on the books in the state of Nevada in statute that requires all the payers in Nevada to use a single form, a simplified form to credential people that are coming in to at least new physicians, and not have an extensive individualized process. And I guess I would ask the commission to maybe pull that statute and look at it and review it and see whether or not there's an enforceability of that in terms of simplifying credentialing for payers. I would echo what Dr. Khan just said also about keeping telehealth reimbursement for and in parity with in-person visits beyond the national emergency time frame, because it's really, I think, it does not increase cost for the payers. It just simply is another way for their patients to get access to care, and simply put, it just makes life easier for us, especially as we're those of us that are Medicaid providers in our state are looking at a potential 5 to 6% across the board cut coming up this week in the special session that's being discussed, and in a state that's already underserved in terms of Medicaid providers. Simply taking two things, two revenue sources away at the same time could really negatively impact access to care, and we already know we have problems.
Thank you. Jessica?
I think that it is important to look at what legislative opportunities are available, but also I think that the state right now is accepting input for the managed care contracts coming up in the next several years. So just looking at like where you could leverage some input or recommendations from the Patient Protection Commission, if there are ways to change the contracts, because I think the state is pretty open to improving those contracts.
Okay, I see Sean has a question or a comment.
Yeah, thank you, Mr. Chair. This is in response to some of the information that Dr. Barron had shared. Coming from a managed care entity, we do our own credentialing of providers, hospitals, et cetera, as was mentioned several times. And as Dr. Barron mentioned, we can be relatively efficient at that. We use an electronic system, it's called CAQH. We go and are able to pull down information from electronic sources. Some of them do require certain primary source verifications, as Dr. Khan mentioned previously. Those can take some additional time, but at least speaking from our organization, I believe we're relatively efficient. We've improved that over the years, and then oftentimes we are more efficient than the state agencies in terms of approving providers. Additionally, what I'd add on top of that, and I'm not a lawyer, so I wouldn't want to speak to them, but I'd be hesitant to try to legislate that private entities follow decisions of public entities automatically without being able to do their own review. With respect to reimbursement of telemedicine, I know this is the Patient Protection Commission. It's not the Provider Reimbursement Protection Commission. I want us to be cognizant of legislating as well. What are individual discussions in the private sector? We have 3 bill drafts, and I want to be cognizant that perhaps maybe using one of them to legislate reimbursement rates between 2 private entities might not necessarily be the best use of our time and resources.
Other questions or comments with respect to work plan? Howard.
One of the things that was brought up previously was the access to telehealth services and expanding broadband. And I think that there's a federal piece of legislation that our senators are co-sponsoring in Nevada currently, that's being considered to try and improve access to broadband for the rurals and so forth. And might be nice for the commission. And again, I don't know if it's a BDR per se, but might be nice for this commission to be supportive of said efforts and see whether or not we can maybe even send a letter of support from this commission to the governor and to our senators to try and improve availability of Wi-Fi access and so forth in that regard.
I see a couple of attendees on the list who will make me smart on that issue, Howard, and I will follow up. Other questions, comments, suggestions on the work plan? Teresa.
Thank you, Chairman. I want to go back to a comment that was made about collecting information from patients in a more systematic way as opposed to an anecdotal way. And I have recommended to you and to Sarah that we develop a survey of some sort that we can deploy to gather that information in a more systematic scientific manner. I know other states that have similar type agendas are doing something, have deployed that kind of that type of state level survey. So just a suggestion.
Okay.
And on top of that, maybe even going to the NGA, because they were bringing up like Indiana, and there's, it seems like they've made some progress with surveys. So instead of us recreating the wheel, seeing what other states are doing.
Yeah, I'm going to take any and all suggestions on how we would collect that kind of information. I agree that representative survey data over anecdote is always preferred. So I don't know if anything is being generated through things like HCAPS or anything hospitals are already collecting, or other entities are collecting that could inform that discussion, but I'm all ears. I believe Commissioner Richardson had a question or a comment.
Yeah, thank you very much, Chairman. So I wanted to go back to your original note where you talked about licensing, and I do know that Indiana is doing a great job, and they actually use those license boards to gather data, which is always really helpful. I happen to also have in the past worked in a state where there was licensing done on a general basis, as in, you use as many consistent requests for the information as possible. It's all done online. That way the MCOs and other people can start relying on that data. But it took the states moving all of those individual boards underneath HHS in order to do that, in order to sort of have a consistent system. And what they did to alleviate the concerns of the providers who were normally the volunteer reviewers on that board is the boards themselves would still make decisions, but the data was collected in a different manner. And so the whole thing moved much faster. And once it was there, it was available for everybody, including the public, to look at, and it was used to gather data pretty consistently. So, the idea that Indiana is already doing this, I think we could definitely look at that. We should look at that. Just want to make sure that you still have that independent issue, because I know that some of the providers would want that.
Okay. Yes, Howard.
Two things. One is I think it might be nice to hear from the executive directors of our current licensing boards as to some data on time from initial application to actual approval, so that we can get a better feel for what is the delay in the process here. Because I feel like too much discussion and effort is being directed at the various boards, and really where the problem is what happens after the license is obtained. Again, that's been my personal experience in credentialing 3 or 4 practitioners here. The other comment I want to make goes back to something earlier, which is having to do with let me think now. You know what? I'll reserve that and I'll come back to it if we have time. Thanks.
And Howard, I wanted to mention in the course of our meeting, I've already heard from one executive director from a licensing board who shall go unnamed, who is willing to provide that information. I presume there will be others. So they're already ahead of you. So.
Oh, great. Actually, I thought the other thing that I was thinking about was in response to some of the healthcare workers who spoke earlier today about PPE and so forth, and availability in hospital settings and outpatient settings and so forth. might be nice to hear from some of the chief medical officers from a couple of different institutions, let's say Valley Health System, HCA, et cetera, with regard to what their current policy is and what and how it evolved and what the rationale is behind dispensing PPE in their institutions. To be fair to all parties, so that we have a better understanding as a commission where some of these issues come from.
That might be information I would suggest we could solicit and bring back to the group. Maybe not necessarily presentations, but I would presume that that's a policy that's been committed to paper, even though it's been evolving. And so might want to recommend that. Teresa,
Right.
and Dr. Sloan.
Well, just to kind of build off of that, I had, that the idea that a lot of places felt like they weren't fully prepared when the pandemic hit, made me wonder what I know some of the major hospitals have pandemic preparedness response plans, but I'm wondering, as you get into smaller facilities, what those plans look like. Are they required by the state to have something like that in place? If they don't, is that something that we can work on, where if they don't have the resources, can there be some technical support, technical advising from state authorities to help them develop these type of plans so that they can pull it out, training, those sort of things. I don't know if that exists, but it seems to me that that's an easy, low cost thing to do. In the event, because pandemics are not going to go away. I mean, everybody in public health could have, is warned that this has been around the corner. So thinking about what the next phase will be, how can we improve our response to better serve patients, and then for all the healthcare frontline workers, how can they be protected to ensure that this, that they don't face some of these structural issues again. And also thinking about being flexible to how the science is evolving. I think that what we heard at the beginning about masks was confusing, and it was confusing to the general public. I think that was mentioned. And also, we're really starting to learn that this is an airborne virus, and that, touching surfaces and stuff is probably a rare way for transmission to occur. So being kind of flexible to that information, and how do we get that out in a systematic fashion, not only to providers, but to patients and to the general public.
Okay, and I believe that future preparedness planning is squarely within the focus of what Caleb's up to, as well as HHS. And I think I will also, when we hear from the local health authorities, make sure that that's something we get comment on from kind of those three various perspectives. Dr. Sloan.
Thank you, Chair. Two quick comments. One, on the issue of telehealth parity, I want to go back to that point. This is not about negotiating rates or anything like this. This is simply about parity, which is an access issue. And on the other piece of that access coin, which is one of the major charges to the commission, I would be particularly interested, given the challenges we've experienced in COVID across the board, for the most vulnerable patients in our state, those receiving Medicaid. We already know some of the challenges with the Medicaid program. We've gone through expansion, et cetera. But what about kids as they go back to school in the fall? What is that going to look like? What preventive surveillance mechanism should we have in place to notice early on if there's an uptick based on what the school districts are planning? Second, what about the mentally ill and access for the mentally ill in this context of limited access to start, and then more constrained access in the aftermath of COVID? Third, the elderly. Wow, that's another group that we haven't really contemplated, but we know, particularly in our county, that the suicide rates from the elderly are very, very high. And these vulnerable populations, I think, represent perhaps some piece of them, an opportunity for better access, and not only generally speaking before COVID, but certainly after COVID, and we should be paying attention to them.
Thank you. Dr. Khan.
So on the subject of PPEs, another observation that we, I guess, need to understand is the perception is that PPEs are now available in abundance compared to where we were 3 months ago. There are challenges in that, and perhaps the governor's task force that has been obtaining PPEs for the state. The challenges, as I see on the ground, is the standardization of the availability of, especially the masks is a big issue, obviously, and there have been a whole bunch of fake, outdated, et cetera, things being sold and sent and what have you. So the buyers, whether it's all the healthcare provider institutions, have to process that. I was involved in one of these distribution components, and there are all kinds of certifications that the sellers provide. They're invariably, almost all the products are from China. They have China certifications, they have European Union certifications, they don't have FDA certification. So it becomes a challenge, even though hypothetically the products are available to purchase, they are not standardized, and therefore the availability becomes more limited when you really get down to the nitty-gritty. And there's a liability issue involved if you purchase these products because of that certification, which is not necessarily good enough for the US. That becomes a whole different issue. So that is something that needs to be looked at, whether the task force can look at in that and provide some guidance to the buyers of various healthcare providers in the state.
And I would like to follow up with what Dr. Khan is saying about PPE.
Go ahead, Jarlene.
Yes, I would like to follow up. Talking about PPE, I had a suggestion I sent to Sarah and Mr. Packham about how maybe the state could be a pioneer in creating a program where we create jobs for people that will make masks, so we have our own supply of PPE in the state. So we don't have to be dependent on suppliers outside of the country or even outside of the state. That was an idea that maybe not a short-term solution, but definitely looking forward for future pandemics.
I think GoEd would love that suggestion. Thank you. Other questions or comments? Okay, in the interest of time, I think that was a good discussion of work plan and potential bill drafts that glad to see taking shape. And it leads into our next agenda item on future agenda items and meeting dates. I believe we're pretty settled on the calendar at this point. We'll be meeting every 2 weeks on Monday at 9, presuming that remains agreeable to everyone and that's in everyone's calendar. I have a number of suggestions for future agenda items, but want to hear from commissioners first. I would like to have us be mindful about that balance between formal presentations that we're looking for, data we're looking for, but more importantly, our conversations about policy recommendations and bill drafts, which I'd like to see occupy more of our time as we move towards Labor Day. With that said, I would like to recommend that we hear from the local health authorities, and in particular, reach out to Southern Nevada Health District, Washoe County Health District, Carson City Health and Human Services, and at least one rural health officer or somebody who speak to those issues. I have a couple of individuals in mind, but have them speak to not necessarily just their perspective on COVID-19 and what's happened, but specifically address a number of issues that this group has raised in this meeting. So vulnerable populations, follow-up after testing, PPE, and again, I don't want to limit it to what I can just recall, but again, speak to issues that a number of you have raised through the course of this meeting and previous meetings. Other thoughts on agenda items for our next July meeting? Dr. Khan.
So another suggestion, I would request that the State Medical Association, that is supposed to represent the physicians in the state, come and give us a presentation about the challenges for their providers, specifically, whether it's the PPEs, whether it's reimbursement, whatever the challenge is, because they are the ones in the trenches. So I haven't heard from them specifically about the challenges of the constituency that they represent, day-to-day challenges, the availability of PPEs, the challenges in their offices, the challenges, whether it's reimbursement, et cetera, et cetera. Reimbursement, I don't want to belabor that point that is being talked about, but we need to hear from them. I have mentioned my views, but they are the ones who need to come to the table and give us a full presentation.
Okay. We can do that reach out. Other suggestions for our next meeting? I would like to, I think we've heard from workers and we'll have hopefully hear from patients later on during public comment, but I'd also like, and again, I'm trying to wrestle with whether we actually need formal presentations on some of these topics, but I would like to see some Nevada-specific data on vulnerable populations, and when we look at the experience across the country, whether it's positive cases, whether it's hospitalizations, whether it's other indices of morbidity and mortality and so forth. There's plenty of data out there nationally on people of color, the elderly, other vulnerable populations that Tony just mentioned and so forth. And so I think that I will have Sarah and I reach out and try to get that information. And again, whether it's a presentation or not, I'm gonna lean towards us putting together data that we can put in front of commissioners and try to avoid the 15-slide PowerPoints to the degree possible, but honor your request for more information where we can get it. Dr. Khan.
So on the vulnerable population, let's not forget the Native Americans who also rely on their access, resources, and that's a huge challenge for them. So we need, in the vulnerable population, let's not forget the Native Americans also that access healthcare within Nevada.
Okay. Dr. Barron, then Teresa.
Would it also be possible, we heard a lot of different comments from different presenters today about communication and the way in which information is communicated, relayed to patients, consumers of healthcare, things like that. And it sounds like there's some lessons to be learned there. And I was just wondering whether there's somebody assigned in our state government that looks at other states and who's doing some communication successfully, and whether there's a way to pull that all together.
Richard Whitley, I know you're on. I don't want to put you on the spot, but I didn't know if that was something that fell within what HHS is looking at in terms of best practices. We can also follow up. Teresa?
Yeah, I mean, I definitely support the last comment. I think that this is complicated. I've said this many times for patients. It's hard. We're dealing with people with a variety on the spectrum in terms of health literacy. And so any way that we can create a message that's simple, and it has to be evolving, but that can get out to a lot of people. I think that's important, and that it's a coordinated response as well, so that we don't have multiple health districts providing multiple different messages. And back to the racial disparities, I don't know how many on the commission follow the COVID tracking project, but they have a racial and ethnicity data dashboard. And for Nevada, we only report race and ethnicity for 58% of our cases and 89% of our deaths. Why we have that low level, I don't know. That maybe Richard can help us answer that question, but obviously there's room for improvement there.
And is that state level data, Teresa, or is that even broken down to?
Yeah, this is for Nevada. I mean, they have it. I don't know if people are following the COVID tracking project. It's pretty comprehensive, but they have it broken down by state. So looking at Nebraska, just above us, they're reporting race for 76% of the cases. So I imagine Richard might have some more insight into why that data is lacking.
Okay. Other questions or comments on agenda item 11, future agenda items? I think we have plenty to work with. Sarah, I don't know if you have any recap, Sarah, or thoughts?
No, but I would be remiss if I didn't mention Jeremy Gladstone took some time this past week as a request from this commission to get some data on Nevada's network adequacy. And I'm not sure if this commission was a part of some of your background meeting materials, commissioners, and he is available for questions during this meeting, but also if there is a request, he's available to make a formal presentation to this commission following that presentation he sent you. So I just wanted to make sure that I acknowledged and thanked him for not only putting that together, but also making himself available to this commission.
Thank you for that reminder. I'd forgotten about that. Jessica.
So Commissioner.
Jessica, then Barbara.
Okay, great. Yeah, so my internet connection has been unstable, but I just wanted to make sure that behavioral health was one of the future agenda items. I think there's a lot of really good information happening around crisis now. And I think that there are a lot of unnecessary visits to the ERs that are occurring with people experiencing behavioral health issues. And there's a lot of momentum around the state to create alternatives to people with behavioral health issues visiting ERs, like crisis stabilization units, and other types of centers. So I think it'd be really good for this commission to be aware, especially in terms of COVID and the potential for being infected and having to visit the ER when you're in a behavioral health crisis, when there are other alternatives out there.
Yeah, and I could probably articulate this with another cup of coffee a little bit better, but I'll go ahead. I consider a vulnerable population is any segment of the population that's postponed or delayed care. So I hope that when we're pulling data together, that's thought of as part of the mix of what we mean by vulnerable right now. Barbara.
Yeah, just real quick, I was going to let Sarah know to contact Jeremy Gladstone also for the certification form and the statutory reference that you were looking for. Because that sits on the edge of the Network Adequacy Council.
Thank you, Commissioner.
Okay, I think Sarah and I have more than enough to try to assemble in the form of next meeting and follow-ups. I'd like to ask commissioners to be mindful again of the time crunch that we're under. So there will be our next meeting, which will fall on July 20th. That will back out to a meeting posting date that we need to be mindful of. And so we will be reaching out to you at some point later this week with a few asks having to do with data, the type of data you would like to see it, whether we actually need formal presentations on a given topic, and then what we need to get that meeting agenda posted the following week in time. So look for some follow-ups from Sarah later this week. Teresa.
Just a quick comment. For all the commissioners, Sarah sent out in her last email a whole bunch of resources, and one of them was from the United States of Care, and they actually, one of the links was for the legislative recommendations, and not to toot our own horn, but everything that we talked about was very much in line with their recommendations for state leaders.
It's a great resource. I second that recommendation, Teresa. That website also has some great recommendations that fall more in the bailiwick of what Caleb Cage is focusing on, and that is some of the issues around preparedness. They've got some great state level resources, and suggested policy recommendations and legislative recommendations as well. Okay. At this point, hearing no further discussion, I would like to move to public comment and first invite and apologize to those folks who were planning on speaking to patient issues and have them step up to the mic if it were, as it were, virtually. And I don't know if Sarah or Leslie is coordinating that.
Sure. Thanks, Mr. Chair. If I can just take a moment and ask Leslie if anyone has submitted testimony to read into the record. And then attendees that are watching and listening, if you would like to speak during this agenda item, please take a moment to raise your hand. I believe it's *9 if it's on your phone. Otherwise, you can hit the raise hand prompt via this Zoom webinar. But I will take a moment and go to Leslie.
Not at this time.
Thank
There
you.
were none.
Okay, Mr. Chair, it looks like we have one person right now in the queue. Let me turn to her. I'm going to ask Jennifer Atlas. We'll go to you first. Let's give her a moment to enter the meeting.
And I'd like to kindly ask those providing comment to limit your comments to 3 minutes, please.
Hi, can you hear me?
We can hear you. Welcome.
Thank you. My name is Jennifer Atlas, and I am speaking today on behalf of the Nevada Dental Association. And we represent licensed dentists in the state, and we're the voice and advocate for oral health care in Nevada. And we respectfully request your potential assistance and administrative support for the Nevada State Board of Dental Examiners. When COVID-19 cases initially spread across the country, Nevada dental offices stopped normal operations on March 16th, only providing emergency services. At the end of April, the Nevada State Dental Health Officer released a multifaceted, comprehensive plan to resume non-emergency dental procedures. This plan was approved by Governor Sisolak's medical advisory team and adopted by the Nevada State Board of Dental Examiners on April 30th. This measured plan allowed patients to safely resume some essential dental care. However, following the April 30th Nevada State Board of Dental Examiners meeting, the board lost its quorum due to the resignation of members. Without direction from the board, the dental community has not been able to move forward with the phase-in plan to allow additional procedures and techniques. The health, well-being, and safety of our patients depends on the continued ability of the entire dental team to provide comprehensive care. As an example, the current restrictions on ultrasonic devices, which help complete scaling and root planning, makes it difficult to treat periodontal disease. Nevadans that have not had this illness treated are being exposed to further destruction of their oral and systemic health. Furthermore, the board's inability to meet has delayed recent graduates from getting licensed, innovations in teledentistry, and regulatory changes to allow dentists to perform in-office COVID-19 testing. We respect the authority of the Nevada State Board of Dental Examiners and feel it is important that the board message licensees in a timely manner to ensure information is complete and accurate. Amid this health crisis, it is important that the board have a quorum to conduct business for the health and safety of our patients and practitioners. And we thank you very much for the ability and time to speak today.
Thank you for joining us. Additional comments, Sarah?
You know what, Mr. Chair, I don't see anybody else who has indicated that they'd like to speak, but I know that there were several patients who wanted to speak and share their stories but weren't able to join us today. So if I may just take a moment, Mr. Chair, I'd like to just speak to the patients who are watching online or listening and just take a moment to let them all know that we have an ongoing open invitation to hear from them, for them to share their healthcare stories. And we ask them to engage with us either by participating during our meetings, and in lieu of being able to participate, they can always reach out to our commission and send us an email to provide written testimony, but just wanted to take a moment to reiterate our open invitation to hear from them all.
And I'll go one step further and just suggest we allow those individuals to be first up on the first public comment in our next meeting. the
Great.
least we can do.
That's it. It looks like we do not have anyone else that raised their hand to speak to us today.
But I believe Dr. Khan has another comment.
Yeah, just an observation. I would be amiss if I don't give a special recognition to Sarah. Boy, she's on top of things. Please don't burn her out. She is back and forth, back and forth. I mean, the emails following up, and she's one of the most prompt ones I've found, that you send an email and she's on it back in a few seconds. So Sarah, keep up the good job, and Chairman, I hope won't burn you out.
I
appreciate that.
I second those comments.
I agree.
Thank you. Mr. Chair, it looks like we do have one person who does want to speak. It looks like another public comment. If I can allow them to enter into the meeting.
Absolutely.
Okay, it looks like Ms. Joan Hall, I'm going to be placing you into the meeting and asking you to unmute your mic.
The meeting would not be the same if we didn't hear from Joan Hall. So welcome, Joan. You're muted though.
There. Thank you. Thank you very much for the time. Joan Hall, Nevada Rural Hospital Partners. Your conversation today about licensing and credentialing is very important to rural healthcare. It has been an impediment to our access to care, the time to get physicians licensed. Your board talked about the efficiencies in technology. I think that is really valuable to look into. Also the discussions about credentialing. The same thing happens in rural. So if you've just replaced one physician that you had with a new physician and they can't get credentialed or licensed or both in a timely fashion, it really impacts care. So appreciated that conversation a lot. Thank you very much.
Thank you. Anything else, Sarah?
That's it.
Okay, now this is going to come as a shock to the commission, and that is, I'm going to adjourn this meeting and allow you to go to lunch at the civilized hour of 12 noon. So until we speak again, enjoyed it. I thought it was a great discussion, and Sarah and I will be following up with you soon. So have a good week.
Thank you. Bye, everyone.
Bye-bye.